We are 12 past 4. There's almost 50 of you who have joined already. And we're really excited that all of you could make some time today for this important session. I'm really excited to have a great group of panelists here who have enthusiastically supported our cause and joined, taking time out from their really busy schedules to be here with all you ladies. I hope you guys can see my screen okay.
Yeah.
Okay. And what we're going to do is, the things I had thought of is, today's session is not going to be about, talking about advances in cancer treatment or oncology. It's designed to be a support group meeting, and the topics we're going to cover are really going to pertain to life after breast cancer and what is the new normal that women get used to, how to cope with certain side effects of treatment, and how to, we do all know that, life after breast cancer is not exactly like the life before breast cancer. And so the goal is to just tease from, a couple of points about how are things different? What can you do about certain things? How do you come to accept the things we cannot change? What are the some of the symptoms you may be experiences for which we do have great treatments, and some of these topics that I thought would be of importance. If you have questions about some specific topics that are not getting covered in this discussion, do feel free to use the chat window to type those questions in, and the panelists can take them at the end of the session. Also, we'll try to make a recording of this session available to those who are not able to join. And this is the first time we're trying to do something like this, so hopefully it's a useful endeavor, and then we can do more of these on specific topics that we aren't able to cover today. I request all the panelists to please keep yourselves on mute so that there's no echo. Otherwise, Zoom is notorious for creating a lot of echo if people leave their mics on, even if you're not speaking. So here we go. So one of the key messages I want all of you all to go home with today is you are not alone in this. And you can already see there are 50 people here already who have joined in, telling you that, you have company in whatever it is that you may be going through. Breast cancer is the most common cause of cancer amongst women in India today. We say that usually the risk is 1 in 25 for all women that live up to the age of 70. In the West, that number is close to 1 in 8. In India, although breast cancer is less common, we do see more complicated and advanced cases when they do come in. In India, we report almost 1.5 lakh cases every year, and the number of cases seem to be increasing each year. So yes, it's a big problem, and you're not the only one going through it, although, at a point in time, you may feel pretty alone in the journey. The other message is cancer is absolutely never your fault. So it's an accident happening at a cell level. It can happen to anyone. So if at all any of you, and you shouldn't, but if at any of you ever have a sense of, okay, what is it that I did? What is it that I did wrong? Please give up that feeling right this moment as you move forward. The third message, there is a new normal when it comes to life after cancer. So, we've learned the year 2020 has taught us a lot about what this new normal is, because, a life with mass was never something that we were used to, yet now that seems to be the norm. And similarly, just after breast cancer, you are going to feel, different in many ways, right? A woman goes through so much of change. You're going to feel different physically, emotionally, some of you mentally, spiritually, and you do adapt. And you adapt in ways that you don't realize sometimes, and sometimes in ways that you do. But life after breast cancer can best be described as coming back to what is not your old normal, but a new normal. And this is the focus really of the topic that we're discussing today. So the other message I want to give you is be kind to yourself. Sometimes you look at, the Facebook and social media life of others and think, oh, well, they have it all and they do it so easily, take it in their stride. And you may have heard of somebody having breast cancer and they did this and they did that, and that doesn't apply to you. Be kind to yourself. You've been through a struggle. take breaks, don't sweat the small stuff. But at the same time, just as a good friend would tell you, you need to tell yourself that, okay, I'm going to be kind to myself. But when it comes to being regular with my follow ups, following my recommended medications, diet, lifestyle, exercise, I'm going to do what it takes to keep myself healthy and happy for my life ahead. And the last message is that there is always, always help available. And I am so, so glad to have all my friends here as panelists who are experts in their fields. And they are always going to be available to guide you. I mean, they've taken time out from their schedules to be here because they are genuinely compassionate people who want to help women who are going through whatever it is that you're going through in your life after breast cancer. And for anything you're experiencing, although you may feel like it's happening to me, there is somebody in this group, I'm sure, who has experienced the exact same thing at some point or the other. So you're not alone. There is help available. Don't hesitate to seek it when you need it. So I'm so happy to introduce my friends and colleagues and panelists here today. Dr. Priyadarshini Kulkarni is a palliative care specialist. She's written a wonderful book, and I'm going to share that link a little later, about palliative medicine. And she herself is going to tell us what that specialty is, but she does a lot of counseling and support work for patients as well as families going through cancer. Another very multifaceted personality we have here is Dr. Rohini Patel. She is a gynecologist by training. She's practicing as a gynecologist. She's a breast cancer survivor herself and a very enterprising woman who has led so much work on breast cancer support for women all over India. She's brought a movement called Knitted Knockers, which provides prosthetic support free of charge to women who are who have undergone a mastectomy. She's also trained herself to be a lymphedema therapist, and she's a certified lymphedema therapist herself. And she does a lot of education work for women about how to prevent lymphedema and take care of their arm after surgery. My third panelist here is Dr. Swapna Athavale. She's a cosmetic and reconstructive surgeon. She's my surgeon partner at Jupiter Hospital, and we run a common OPD there for women who actually do want to discuss reconstructive surgery after cancer, or who have certain cosmetic breast problems that need to be dealt with, and we take care of those problems together. Our fourth panelist is Dr. Sharada Umarani. Dr. Sharada is a physiotherapist by training. She has specialized in oncological rehabilitation, which includes, basically getting women back on their feet, getting their arm function normal after having undergone breast cancer. She's also a Pilates instructor, and she's going to talk about some of these skills of hers later. Shilpa Shirole is a registered dietitian. Her specialty is nutrition. She does a lot of work with cancer patients, and she's going to clarify all our doubts about what to eat, what not to eat, and we'll have some questions for her. Our last panelist is Dr. Mina Lagarwal. She's a gynecologist as well, but she has specialized in medical genetics. She works with GenePath DX, and she does genetic counseling. So she's the person to go to when you want to discuss hereditary breast cancer and risk. And we'll be having some questions for her as well. So as an introductory slide, I know everybody who's been through cancer has some symptom or the other. And the burning question always is, what are the symptoms I need to worry about? I know a lot of you feel, you call me, like every time you have even a cough or cold, you're always worried about, okay, is this cancer? What do I need to do? And no, not every cough and cold is cancer. Yet I'm absolutely very happy to receive those calls so that we can, I'd rather you not worry about it alone at home and get it sorted, whatever it is. But broadly, I will tell you that any symptom that you're feeling, you should run it by your oncologist or breast surgeon, whoever is accessible to you, and figure out which category does this symptom belong to. Is this one of those symptoms that is a red flag and I need to, investigate it? Is this a minor side effect, yet there is some treatment that we can offer you for it? Is this something that is a lingering side effect, but this is going to be something that is going to be part of your new normal, that there is not much we can do about it. And you simply have to get used to working around whatever symptom and limitation it may be. And every so often, a symptom you may be feeling may have nothing to do with breast cancer at all. And the people who need to guide you about which of these categories something belongs to, the best people to do that are going to be your oncological team. So, coming to the most worrisome and burning questions that everybody has is, what is the sign of recurrence? When should I actually be worried that something could be cancer? Well, I will tell you this in a broader picture, that symptoms of recurrence are not usually going to be subtle. They're not going to be like a minor cold you have today and don't have tomorrow, or a headache you got in the morning and disappeared in the evening. That is not what a recurrence looks like. But there are symptoms that you shouldn't ignore. And the local symptoms, which means around the area of your surgery, if you have any new nodules, a new rash, a wound, a lump, a swelling in the neck or swelling in the armpit, those are symptoms that need to be investigated. So I don't want a woman who's had a mastectomy to think, I just think I have this rash, let me apply some ointment around my surgical site. No, if you have a rash around your surgical site, if you have something that looks like an insect bite around your surgical site, but it hasn't gone away for a week, you need to come and see one of us. And general symptoms, if you have a cough that is, say, persistent, which means you took, your prescribed course of antibiotics, you're not feeling better, it's always there, you're feeling short of breath, there is blood in the sputum, you have a headache that hasn't gone away for a long time, maybe 2-3 weeks you've given the medicines you need to take, and the headache hasn't gone away, or a new seizure that you suddenly get. These are going to be usually dramatic signs. A bone pain, or aches and pains around your fingers and toes might be very common, especially if you're taking aromatase inhibitors like Arimidex, Femara. But if suddenly one bone hurts, it keeps hurting at an odd position, it's the kind of pain that wakes you up at night, it hasn't really gone away, even if you've taken medicines, then yes, we're going to do some imaging. Now, just because you have some of these symptoms doesn't mean that you have a cancer recurrence, but we may ask you to do certain investigations to figure out what is and isn't related to cancer. Again, loss of appetite. Suddenly, if you have jaundice, you can't assume, oh, it must be because of something I ate. You have to get it investigated completely. Unexplained weight loss. Well, if you're doing a great diet plan and you wanted to lose weight, great. But if you weren't intending to and suddenly you're losing weight, then let's get that worked out. So this comes into the category of what symptoms you're not going to ignore. Then there is the next category of symptoms, which we talk about in the new normal. And we'll be discussing some of these with our panelists as well. That, after you've had, say, lymph node surgery, some of you are going to experience, in fact, most of you are going to experience a numbness along the inner side of the arm. It's a very, very common symptom. It's not going to go away because we've actually surgically interrupted the nerves that go into that area of the arm. So that symptom is there to last. Another symptom is when you're recovering from surgery, you may have pins and needles kind of sensations, aches and pains that are sharp, they're stabbing, they come and they go. So you feel it 1 second and 10 seconds later it's gone. That is all because of nerves being cut at the time of surgery. And that's again one of those symptoms that will stay. Changes in the skin after radiation. So there is a little bit of redness, and some people have sometimes minor blistering right after radiation. But even several months after radiation, the radiated side may feel like the skin is a little thicker, the pigmentation may be different, and some of that may last for a very long time. So that is another change, what should be thought of as a new normal. Some of you may experience some side effects after chemo, something called chemo-induced peripheral neuropathy, where there is some discomfort in your hands and feet, which may be tingling, numbness. Occasionally, women may have some weakness of their fingers as well after having received certain types of chemo, especially taxanes and platinums. And it doesn't happen to everybody, but it can be a very, very frustrating thing to have if you've undergone chemotherapy and don't have that, feeling that you had before in your hands, that you could do fine tasks with comfortably. And so that is another complaint we'll be talking about. Small joint pains in the fingers and toes, like I said, are very common in women who are getting letrozole and anastrozole. If, however, this becomes really, really significant, where you're not able to walk, it's really bothering you, it's making you, not get out of the house, or it's significantly lifestyle limiting pain, there are certain changes we can make to your medication regimen, but you need to talk to your oncologist about what alternate drugs you might be able to use if this is actually bothering you. Then there are some hair and nail changes after chemo. Most of the time we say, hair loss after chemotherapy is not a permanent feature. The hair does grow back. It sometimes is of a different texture than what you had before. Nail changes, again, are common after chemotherapy, and those also improve with time. So these are some of what we call as the changes of, what your body has to kind of get adjusted to after having been through breast cancer treatments. So the next category of symptoms we'll be talking about is the ones that can be treated. And one of my pet peeves is pain. I don't want any of y'all to actually be living with any degree of pain that is significantly lifestyle limiting or depressing. There is always something we can do for pain. And Dr. Priya I'm sure will agree with me that there is also a technique that, there are some women who have a particularly severe degree of what we call as post-mastectomy pain. So if they've had surgical removal of the breast on one side, or sometimes even in women who've had lymph node dissection without removal of the breast, and even if they've had the breast preserved, sometimes in women who do have a reconstruction as well, they may have significant pain where they're having trouble raising their arm because of pain. They're having trouble with doing physiotherapy and exercises that we ask you to do because they have pain. There is something that we can do for this pain, and a lot of times it's about breaking a cycle of pain. And for this, often I might give you some form of anesthetic blocks. We call it a pectoral block, sometimes a scapulothoracic block. And what that does is it breaks the pain cycles. Then we may give you a course of anti-inflammatory medicines. We may ask you to do some hot fomentation to the back. We may ask you to do certain prescribed physiotherapy exercises. So there is always something we can do for pain. Another symptom that we should definitely address and treat is depression, arm swelling, hot flashes, anxiety, sleep disturbances, sexual dysfunction. All these symptoms can be treated. Do bring it to our attention. We are sometimes not very good when you come for your cancer follow-ups. We're kind of, just checking you out physically and saying, hey, everything looks good. See me back in 6 months. And everything is actually not good, because when you go home, you're dealing with some of these side effects by yourself, getting anxious. And so when you do come for your follow-ups, make it a point to list some of these problems you may be going through, and we can talk about them. And we'll obviously be talking about these with our panelists. So our first question for our panelist is for Shilpa Shirole. So women are often prescribed these, rigorous diet plans, right? Where somebody or the other is always asking them, please have this, please don't have this, please eat this, please don't eat this, to the extent that a woman almost believes she can eat her way either out of her recurrence or prevent cancer by eating right, or she's going to get cancer just because she ate something wrong. And none of that we know is actually true. So what would you tell women about following a diet? And sometimes I've had women who've come in with significant weight loss. They're vegetarian and somebody told them don't have milk. And now they absolutely have no idea what to eat. So what would you tell women about a diet after cancer? What can they and can they not do?
Okay, good evening, everyone. I hope you can hear me well.
Yes.
Well, when we are talking about diet, what we need to keep in mind is have a nutritious and a balanced diet. That is very important, that you know that you need to eat, and you shouldn't avoid just because, people around you are saying this is good, this is bad. Talk to an expert and always get it cleared. Now, these few foods that have been, are on the screen. First, let's just start with milk. Now, milk, as you know, gives us protein, and milk also gives us fat. So the best way out for us is going for a low-fat milk substitute or low-fat milk. Now, when we are talking about substitute, it would mean you can have other alternatives for milk, other protein sources. You can also have soya milk. I'll come to soya and the myths around soya also shortly. So first is that going for low fat milk. When we are talking about low fat milk, what I normally say is use yesterday's milk today. That means we boiled it twice. In India, especially, you can remove the cream. Nowadays, we also get slim milk or low fat milk. That is, toned milk, which is around 2% fat. So that is ideal. You can go in for that kind of milk. So when it comes to milk, go in for the low fat version. And all the products like curds, tea, coffee, everything that you're going to have which has milk added has to be the low fat milk. So that is about the milk. Now, talking about soy, now soya has a lot of controversy attached to it, whether you should have, whether it increases the risk of cancer or recurrence of breast cancer. So basically, all these studies which have been conducted for the increasing in the risk for soya are animal based. And the way animals handle these nutrients are different compared to humans. There is no human study which says that, soya will accelerate the recurrence of the particular cancer. So we can have soya, especially for vegetarians. It is very important because it's a very good source of protein. So the best thing that you can do is you can go in for tofu, you can go in for soy milk. That is really good and it helps excellently, especially in getting all the protein that you require. Now, acidic foods, well, there is no food as such which is going to change the pH of your body. Yes, people say an alkaline diet, foods which are alkaline, which increases the alkalinity of the body. But there is nothing like, the food is going to change the pH. The body has its own mechanism of maintaining a proper pH. But when we are talking about acidic foods, let's just say that the foods which have to be avoided are foods like, the red meat, the non-vegetarian foods, the processed meat. All these are anyway acidic in nature. So if you look at it from that point of view, the foods in a healthy diet, which we are avoiding anyway, are slightly on the acidic side. So when you're going to cut down on the red meat in your diet or the processed meat in your diet, automatically the high fat milk products like cheese and all these, if you're going to cut down, automatically the pH of, the diet, if you are bothered, I would say you shouldn't be bothered because that is not it. Actually, no food is going to change the pH of your body. Your body has its own way of maintaining the pH. Rice after surgery, it's a very interesting question. Now, what happens is many a times there may be nausea, you may not feel like eating. In that case, yes, you can have a bit of rice. But when we are talking about a healthy, balanced diet, then you try and increase the whole grains in your diet. And when we are talking about whole grains, it would be wheat, jowar, bajra, a whole lot of other millets would come in the picture. And in that case, rice can be reduced. But nowadays we have brown rice also, so that can be included. So again, rice, when we see, it is in totality of the plate that you need to see. If your plate is going to have one bowl of salad, one bowl of cooked vegetable, then little rice is not going to do any harm. So kindly, if you are a rice eater, just see to it that you balance out your plate really well with a lot of fiber and other protein sources. So then that meal becomes balanced. Wheatgrass, yes, there are many studies for wheatgrass, which, basically wheatgrass being green, it has a lot of antioxidants. It has vitamin A, vitamin C. All these antioxidants are anyway going to help the body rejuvenate. So you can have wheatgrass. It's easy to make at home. It is readily available as powders and pills also nowadays, but this is something, it is optional. It's not something that you need to take in as a medicine every day. If you like it, you can have that. Or then, you can have green salads. You can have a lot of green leafy vegetables, have orange and yellow color fruits and vegetables. That will also give you all the required amount of nutrients that you take. And coming to the last point, meats, red meat, yes, surely you need to avoid processed meats, smoked or tandoori, red meat especially. It could be beef, ham, pork, all the processed meat that is available. Kindly, you need to avoid that in the diet. White meat, eggs, yes, and depending upon your total protein intake, we can always calculate and we can permit that in the diet.
Thanks, Shilpa.
I
So
think, yeah.
Great points. Couple of things I'm going to add are going to be, yes, as a surgeon, I get asked, right after surgery, if I eat rice, are the stitches going to come apart? And that's a big, time myth. No such thing is going to happen. If you're diabetic, obviously don't increase a whole lot of rice right after surgery and raise up your sugars. but otherwise rice is no criminal. And wheatgrass, when I ask my medical oncologist what they think about wheatgrass, because everybody's worried about counts dropping after chemotherapy, and they want to know whether wheatgrass is an option to bring up their counts. And one thing you have to realize is that the counts dropping after chemotherapy are not because you have some nutritional insufficiency. It's because we've done an actual act of trying to kill fast dividing cells. And the mechanism that your counts dropping is exactly that, because we're giving you chemo that is working to kill. And so, what happens is, if you are trying to do the homegrown wheatgrass, you're growing it in a pot of plant and then trying to eat something raw, that is not what we recommend right after chemo. So, although wheatgrass has its value, when you're actually going through chemo, I want you to eat fresh, home cooked, well cooked food. So, that is just another point that I wanted to make. So, when you're planning a diet after breast cancer, like Shilpa said, and there have now been studies that show that women who have a diet that is rich in fruits, vegetables, legumes, and you compare that to a group of women who are eating fast food, fatty food, sweets, and calories, you're going to see fewer breast cancers as well as fewer breast cancer recurrences in women who are eating healthy. But that doesn't mean you punish yourself on a day to day basis and eat some form of really punitive diet. That is not something you should do. And I'm sure another point Shilpa will agree with me is, don't try fad diets that you cannot sustain, right? So the next point that I'm going to ask you is weight management, because we do know that cancer patients who maintain a normal weight actually have lesser risk of recurrence compared to women who actually do gain weight after their breast cancer treatment. Surprisingly, with the kind of chemo regimens we use, women think, well, after chemo, I'm going to have weight loss. That's not really true. A lot of times, because of the supportive medicines we give you, some of them are given steroids and whatever medicines, they may actually increase weight after they've gone through chemotherapy. So, you do want to make sure that you're maintaining a normal weight. Now, if you've always been an overweight woman, now suddenly we are making you conscious about your weight. And sometimes women start doing fasting and really extreme diets, and we really really don't want you to do that. Go systematic about your weight loss plan. But I want to ask Shilpa, what would you ask women to do when they're trying to lose weight? How can a dietitian help them to plan out their diet?
See, firstly, when we are talking about weight management, as you rightly said, what if someone was overweight prior to the surgery or prior to the treatment? So one thing that they need to know is what is their healthy weight. So ideally speaking, as per the BMI categories, if we say for Indians, something below 23. But I would say even below 25 for someone who is on the higher side. So first know what is your target weight. That is very important for us to know. And then don't be over ambitious to achieve that particular weight. The second thing is always good to know that are you taking any medications, or is your treatment leading to any water retention or weight gain due to treatment? So that is a thing, because what happens is many people start following the diet that has been prescribed, but they don't lose weight, and then they start losing heart or losing hope, and then they end up eating something that they should not eat. So weight loss may not come, it's not something magical that it is going to happen overnight. You do need to follow a very, very proper diet, wherein the carbohydrates or the cereals that you're consuming do need to be restricted. What we have seen is that if you're going to have around 55% of your total calories coming from carbohydrates, that is your cereals and, the pulses, everything together, that really helps getting the weight down. Very important is how much of fruits and vegetables you eat. What we say is that have at least minimum 5 helpings from this particular food group. That means 3 vegetables and 2 fruits per day. Out of that, at least 1 vegetable has to be green vegetable, and 1 has to be orange or red. So what you're doing is, along with the fiber, you are also giving the required amount of antioxidants that are required. Very important is the amount of fluids that you're taking. You do need to keep yourself hydrated, have a lot of fluids, and stay away from all the fried foods, excess oil. What we say is oil should be restricted to somewhere around 2 to 3 spoons per day for that particular individual, not a lot of oil in the diet. Going for healthy oils. And dry fruits, if you do want to take say around 3 to 4 dry fruits at one time. Do not have something like a bowl of dry fruits, because dry fruits do have healthy fats, like if you're going to talk about almonds and walnuts or flaxseed, also they do give you omega 3. That also is going to help you mobilize your fat in the body. And very important is walking. At least some exercise has to be coupled with diet, because that way you're going to increase the BMR of your body, and slowly, slowly that will help you burn the fat. So it is very essential that whatever diet has been prescribed to you, which is basically going to be a high fiber diet, which is going to have a lot of fruits and vegetables, it's going to have whole grains, refined cereals like maida, bakery products will be a total no. So stick on to that diet, and then slow and steadily start increasing the amount of exercise that the individual is doing. That way it will surely help them. And I think there's one thing about intermittent fasting. Well, when you're,
Yeah,
yeah,
women often ask, like, well, am I going, if I do intermittent fasting, I'm going to be fasting my cancer and I'm going to be starving those cancer cells. And that's how I'm going to prevent cancer from coming back. And so, what do you
see,
have to say about?
see, basically, it is calorie reduction. If you're going to reduce the total energy that you're consuming, it is going to protect you. So I don't believe that, because intermittent fasting in an Indian scenario, there aren't any studies, and, we haven't actually, whether you're going to eat, have that 16 hours of fasting or more than that, it hasn't yet been studied on humans that well. It is more on animal studies. So you shouldn't actually, as you said, do not follow fad diets. So just wait for that. Basically concentrate on reducing the total energy intake, the calories that you're consuming, and that will achieve the benefits. You will get the benefits with that.
Thank you. And I'm sure,
Yeah,
like, just simply the chapter of weight management is several volumes when it comes to a dietitian's book, but
true,
thanks
true.
for briefly explaining it to us. But I think I would encourage women that, take charge of your weight plan. If you are overweight, there's no reason to be awkward about it. And if you set yourself reasonable goals, get the help of a dietitian, get the help of an exercise therapist, and work on it, because there are, like I said, there are people who are out there just to help you for these specific reasons. So the next question is going to be for Dr. Sharada. Dr. Sharada, we now have studies in breast cancer that have shown that women who exercise have a lower risk of breast cancer recurrence compared to women who don't. Right now, I have 70 participants here. And if all of them decide that they're going to exercise compared to not exercise, we are going to see fewer recurrences in this group of women who are right here today. So, exercise is the one most important thing I want women to take away from this session, that if you exercise, that's one thing you're going to actually do that does have an impact on breast cancer recurrence. So, how would you tell women to get started? Because everybody thinks, oh, yes, one of these days I'm going to get to it. Or right in the beginning of the lockdown, everybody was on an extreme fitness regimen, which has now died down because everybody is bored out of what they were doing. So, what would you tell women? How do you get started on an exercise plan after having been through breast cancer treatment?
Okay, so before going to the women, I would like to address all the relatives who are, attending this, that we have this beautiful, what we can say, thing that we pamper our patients too much. I think when it comes to cancer detection, it is always like I have few of my patients whose relatives just come and they're like, आम्ही त्यांना सगळं हातात देतो, like we make sure that she gets everything in her hand, and she does very little work. So I want all the relatives first to know that there's this thin line between caring and over caring, and the moment we stop treating them as patients, they are going to recover quickly. So make them do their daily activities as soon as possible. Now, coming towards all the women who are going to start exercising from tomorrow, from coming Monday, from 1st of this month, after the family function ends, once the rainy season stops. So we have so many reasons to, delay the exercising process. So I think this happens because we look at exercise as a task. And how about looking it as a happy habit of your daily routine? So for that, I would like you all to, first see what you exactly like. Like few patients might like cycling, few might like exercising through dancing and aerobics, few might just like walking. So I would like you all to first see what is your calling, what gives you happiness, so that if someone likes doing Zumba,
And
go
then
for it.
it's
If
not an
going
option.
alone, if
Hobby
going
cannot be sitting on the couch and watching
yeah,
Netflix. It has to be
exactly.
something that
So
gets you moving.
yes, exactly. So go for it. And if going alone is another excuse, like I can't go to Zumba class because going alone is so boring, take your friend along with you, take your relative along with you, or if you have a very nice close group of people, you can even arrange group therapy sessions for you all. So all I want to say is that the moment you'll start stop looking at exercise as a task or something that my doctor has told me to do, or else I'll be in a problem, you'll be much more healthier. And we have always this thinking that exercising is only for reducing weight, and if I fit into my old clothes, that's the only purpose for doing exercises. So I want you all to look beyond that, that regular exercises, the studies have proven that regular exercises improves your immunity, it improves your mental health, it improves your lung capacity, it improves your heart capacity and health. So we have so many gains. So just stop looking at it as a weight loss or just for the what you I can say temporary result. So it has a very long term effect. So I would like all of you to start exercising either from today or from tomorrow morning, like for sure.
Very valid points and great point. You just have to find something that you love and enjoy and then be happy to do it every day. Now,
Exactly.
there are some patients who have genuine limitations. Like when they come for their follow up, they tell me, well, doctor, but I have a bad knee, so I can't really exercise. And then they are also overweight, but then they can't lose that weight because they have problems like joint pains. Others actually do have heart health issues already. They may have had it even before their breast cancer treatment. Some have had issues with lung capacity. So, how do you, when you're working with such patients, what do
Okay.
you tell them? Is there something they can also do? Because it's always an excuse.
Okay. So I'll tell you a short incident which happened literally yesterday. I had a patient who came to me from Dure. So she was like, "Ma'am, I'm doing all the exercises," and I was so happy to know that. And I was like, "Ki काय exercise करता है तुम्ही? Which exercises are you doing?" So she was like, "I am doing the hand exercises you have told me." So for us, like doing only shoulder exercises is considered as exercising. Now when it comes to the patients who have what I can say orthopedic problems or some cardiological problems, we always have this excuse that we have knee pain, I have dyspnea, that I have difficulty in breathing, so I cannot do exercises. So for all those who have such comorbidities, I'd like to tell you that even a bedridden patient can do exercises. They do move their limbs as much as they can. So, no matter how big another comorbidity you have, there's always a way out. The only thing you have to do is consult your physiotherapist or exercise therapist or your doctor, and they can definitely design a personalized protocol for you. To give you an example, I'd say if a person has some heart problem or lung capacity problem, what we usually do is we assess their cardiorespiratory functioning. Like there are few tests such as 6-minute walk test, or we check their lung capacity, and depending upon that, a specialized or personalized exercise protocol can be decided, that how much this person should be doing aerobics, how much muscle strengthening should be done. So, to all those who have excuses such as I have osteoarthritis, I have this, I have that, consult to a proper therapist. You will definitely get your way out, and we can definitely plan your way of exercising.
Thank you so much. Those were all beautiful points. And along the lines of the same, along lines of exercise, another very important point that comes up after breast surgery, and it's a complication really. Lymphedema is swelling of the operated arm after you've had lymph nodes removed from the armpit. And not every patient has had this part of the operation. A lot of times today, what we are doing is a selective lymph node removal, something that we call a sentinel node biopsy, and that has contributed to decrease in risk of developing this arm swelling. Yet, um, there are certain operative techniques we use today as well, something called as axillary reverse mapping, where I inject blue dye into the lymphatics of the arm and try to stay away from them when I'm actually operating on lymph nodes for the breast. So there are things we do which have decreased lymphedema risk over the years. One is simply because staging has become such that women are coming in with earlier stage breast cancers today than they did 10, 20 years ago. That has decreased lymphedema. The technique of using sentinel node biopsy, some of us are using this ARM technique, that has decreased lymphedema, yet it is a significant problem in breast cancer patients. So even women who have had sentinel nodes removed, some of them, 5 to 7% of them, do have risk of arm swelling. So I'm actually going to ask this question first to Dr. Rohini Patel. Dr. Rohini Patel is a gynecologist. She's a breast cancer survivor herself. And herself, she decided to educate herself on this aspect of lymphedema management and lymphedema prevention. And she does a lot of educational work in this space as well. So Dr. Rohini, what can you tell women about how they should care for their arm after they've had breast cancer surgery and lymph node removal?
Look, this lymphedema, each and every breast cancer survivor has a lifetime risk of developing it. Whether it is a sentinel lymph node biopsy or is it a axillary lymph node dissection. Each and every one of us is having a lifetime risk. And the preventive or decreasing the risk things start immediately after surgery. So immediately after surgery, for between 7 to 14 days, the range of movement of the hand should not go beyond 90 degrees, which helps in regeneration of lymphatics, which prevents the development of seroma too. So this has to be kept in mind immediately post-op, that the range of movements should not be more than 90 degrees. And we do have so many questions about whether the exercise should be done, whether exercise increases the after 14 days, very slowly one should increase the range of the movement, that is from 90 degrees to 180 degrees. And this muscular movements facilitates the the flow of lymphatics. Like other vessels, the lymphatics doesn't have that pulsations. So this muscular movements, when you do the exercise, this pushes the lymph nodes forward towards the axillary area, as well as the stretching of the hand. So exercise, stretching, and one more thing is asked about the weightlifting. Yes, weightlifting can be done, but then this weightlifting should be progressive. Once you find that there is something, you feel pain or you feel discomfort, you should stop at that very moment. So it is concerning about the exercise, the stretching, and the weightlifting. Then comes the, care of the hand. The hand should be always kept very clean, dry, special attentions to the ridges and the webs between the fingers, and it should be moisturized, because if you don't moisturize it and hand is dry, the skin is dry, it breaks, and this breaking of the skin somewhere predisposes you to infection, and then this infection predisposes you for development of lymphedema. So the skin care, the nail care, the way you cut it, you should avoid the injury. The cuticle cutting should not be there. When you are working in a garden or in the kitchen, you should be wearing a glove. When you are going out, you should be protecting yourself from the insect repellents. When you are going in sun, you should be wearing a sunscreen where the sunburns should be avoided. And then the blood draws and the injectables. if suppose you have undergone a sentinel lymph node biopsy, but still you have got 5% chances of having lymphedema, so you should be using the other side, which is unoperated. But then in that case, if suppose you are bilaterally operated and bilaterally lymph nodes are removed, and then there is a big question mark which hand and which from where you are going to have a blood draw. So in that case, it's the you should be consulting your doctor, where the lymph nodes are number of lymph nodes removed are less. That would be a side which is less risk of having the lymphedema, that can be used, or your lower limbs have to be used. And then comes the clothings and the jewelry and the watches and the finger rings. So anything which would be constricting should be avoided, whether it is an elastic on your sleeves which would be compressing it. The BP cuff should also be avoided, and as well as the watch which is tightly constricting your hand and the finger, and any jewelry, it should be avoided. And thirdly, the bra, which should it should be very comfortable, which should be having a broad strap with no underwired bras. This should be what you should be taking care of yourself, to reduce the risk of developing a breast cancer. We cannot say you can absolutely prevent developing it, but then yes, you would be reducing the risk of developing breast cancer related lymphedema. And aging itself is a risk factor for developing it. So muscle strengthening, I would say, is always required, which supports the lymphatics and which helps in pushing back the lymphatics to the. So that is how you have to take care of yourself.
Beautiful points, and all very, very important points. Dr. Sharada, do you have anything else to add in preventing lymphedema? Otherwise, we can go on to the
Just
next.
one more thing I would like to add to it, that no massage, no sauna, no hot water baths, for a long time. That is also to be considered. And if suppose you have any redness, increase in the temperature of the limb, you should be consulting it. Look for the signs of infection, redness, pain, increase in temperature. You should be taking care of it. If you have cuts and burns, however small it is, treat it as a major injury.
Right. And I encourage women, to ask for antibiotics early if they see any signs of infection or injury in that affected arm, because that can just trigger a lot of lymphedema. So, Dr. Sharada, do you have any other points on prevention?
No, nothing as such, because Rohini ma'am has like literally covered each and every point. So
So
I
what
don't have
about
anything to add.
managing lymphedema once you do get it? What are some options? And this is a very frustrating condition for women to have. They start off with prescribed therapies. Sometimes they start off with massages, and a month later they've stopped doing it. The lymphedema is back, and they're very discouraged that, okay, well, I did what I needed to do, and I still have lymphedema. So how do they need to manage lymphedema when they do get it?
Okay. Oh, yeah. So I think the treatment protocol will be decided depending upon patient's physical condition as well as mental condition. So talking about lymphedema, there are various factors which are important to look before starting with the treatment, such as which type of surgery is done, then stage or grade of the lymphedema, I can say. As Roni ma'am said, age also matters a lot for this treatment. Another thing, mental status, and along with that, physical status is also important of the patient. Um, as I said, there are stages of lymphedema. Like initially, when lymphedema starts, a patient might have just swelling which comes and goes away on its own. Then, in later stage, it just stays for longer duration, and then there comes this like late stages where the swelling won't go even after exercising, or the elevation after the elevation of the arm. So now, when lymphedema patient comes to us, we first do the assessment. We check for the volume difference of the normal hand and the affected hand. Measurements are taken to see the actual differences. And then exercise, initially we try to plan and reduce the swelling through exercises. But if that doesn't work, we can always ask them to use compression garments. So compression garments are sleeves or compression sleeves which we use. Also, we have options like pneumatic compression, which is, we can say, mechanically, or there's this machine called as lympha press, that mechanically pumping movement of your arm is done. So pneumatic compression can be used. And another option is also multi-layer lymphedema bandage. So again, all these options are dependent upon the stage and sensitivity of the skin and condition of the patient. So these are the options a patient can go through if she has lymphedema.
Thanks, Dr. Shilpa.
Oh.
And Dr. Rohini, what would you say about making a routine around caring for your arm once it does have?
Yeah, I would like to add to once patient has a lymphedema, and one it should be made the patient to understand that this is going to be a lifelong maintenance therapy. It's not it is not going to be that you take a treatment and you leave it and then it will be staying in that way. This has to be counseled to the patient. So, because so many patients, they come back and they say that madam ये तो लिया है पर हमको किसी ने बताया है कि इससे कोई फायदा नहीं होता, ये तो फिर से आता है. So to begin with, one should explain them. I always keep on telling them that आपको अगर डायबिटीज होता है तो आप दवाई लेके छोड़ते नहीं है, ये लाइफ लॉन्ग दवाई लेना पड़ता है. उसी प्रकार अगर आपका सर्जरी हो गया है ब्रेस्ट कैंसर के लिए और आपके लिम्फ नोड निकल चुके हैं, so you have to care for it lifelong. Then we have to teach them the exercise, and most important is self manual lymphatic drainage. That is a manual how you do it. And then that, if suppose along with the exercises they are doing, that is redirecting your lymphatic load towards the whatever lymph nodes are available, and that is something which you go by physiological thing. Once you do a manual lymphatic drainage, then you can support it, prevent again recollection by putting a compression bandage. But people always think that rather than going in for this, मैं compression bandage ही लगा लूं, मैं compression sleeves ही पहन लूं, but then that doesn't help. Once you drain the lymph first and then you give a compression, that would stay for a long time. So that is what it is very important.
Right. So, like you were saying, a woman needs to make a routine around her self-care for her arm. Just like we wake up in the morning, we brush our teeth, we comb our hair. We're going to dedicate a few minutes to caring for that arm in the morning and again before you go to sleep. And I think it's just a matter of making it a habit. It's a frustrating side effect that to have, but if you have it, you should deal with it the best way that you can. And we have some great resources here to help you manage that. Now, the next point is about what investigations should I do after cancer? And I'm going to take that point myself. That as a breast surgeon, I will tell you this, a lot of times women who have had, let's say, a lumpectomy on the right side, a woman's had a breast cancer operated on the right side. She's focused all the time on that particular side. Now, it's important that you keep up with doing regular mammography for the opposite side. Even if you've had a mastectomy on one side, if you still have the other breast, you need to undergo regular mammograms for each breast. Second, if you've had a lumpectomy, there are a lot of changes in the breast. There may be some thickening of the skin, there may be some lymphedema of the breast, there may be some scarring, and it's very hard to discern by physical exam alone, either for you. If a self breast exam is not as reliable after having undergone a breast conservation surgery or a partial mastectomy or a lumpectomy, whatever you want to call it, breast self-exam is not going to be as reliable as what it used to be once upon a time. Same thing, a doctor's physical exam is also not going to be 100%. So for the operated breast, I usually recommend having a baseline mammogram 6 months after surgery, and then we may go to annual mammography for both sides. It's important to undergo good quality mammography if you're going to go get one. You are no longer going to go to the around the corner shack who has some shabby old time technology for doing mammography, because that is practically useless. So once you've had breast cancer, I want you to go get a proper digital mammography, sometimes with tomosynthesis, because our goal of doing this mammography is to pick up any sign of recurrence before you've had a chance to feel something, before I've had a chance to feel something, and get it dealt with early on. So that is important, the technique of mammography. Women who are on aromatase inhibitors, or women who've gone through early menopause, women who are taking Femara, Arimidex, and whose ovaries are no longer working because we gave them chemotherapy, or we may have surgically removed their ovaries for whatever reason, they are at risk of osteoporosis. And so we will give you calcium, vitamin D supplements. Some of you may be put on specific medications for osteoporosis. So you do need to monitor your bone density as well. Depending on what your bone density is like, we may ask you to do these exams once a year. Some of you in the early stages, we may ask you to do it once in 2 years. We also check your vitamin D levels because, again, vitamin D being normal is really important for your bone health as well as your breast health. There is a temptation for every woman that, should I just go get a PET scan every year to make sure I feel good? And we don't recommend that. If you've had an early stage breast cancer that has been completely treated, there is no value in doing these once a year PET scans. They're expensive tests. You may sometimes pick up something called as false positives, which means something lights up somewhere, a lymph node lights up in the chest, something that's an inflammation lights up in the neck, and it causes unnecessary anxiety and biopsy and investigations. So unless you're having specific symptoms, or you've had a type of cancer where your oncologist asks you that, you had disease at X particular point, which I can only assess with a PET scan, or you have a certain group of symptoms where I want to look at a specific area that will be looked at with a PET scan, that's when I may ask you to go get one. I think another thing important to know is when you have had cancer, all your focus is on doing your regular tests for the cancer alone. And you forget about the fact that just like everybody else does, you need to get your blood pressure checked. You need to get your blood sugar checked. You need to make sure your heart is okay. Because our whole point of treating you for breast cancer is so that you can go and live a normal expected lifespan. And we don't want you to neglect other aspects of your health and well-being just because you're a breast cancer patient and you're only worried about breast cancer. Yes, stay on top of your oncological follow-ups. Usually at every appointment, we're going to tell you when you're due for your next follow-up. If before that you have any concern, I know all of you feel very free to come in and drop in and chat about whatever it is that you may be going through. But keep that practice, focus on your other health problems as well. See if, go for your annual gynec checkup, go for your annual physical exam with your physician. And these things are just as important. So now we come to another point, which is, what about my family? Are they at risk if I've had breast cancer? Women who have daughters are always worried about their daughters. Are they at risk? And so today we have with us Dr. Mina Lagarwal, who's a geneticist. And Meenal sees our patients for genetic counseling and testing. So I do a fair amount of genetic counseling myself because I had a fair experience of doing it in the US where I trained. And there are certain, Dr. Meenal is always a phone call away about when I have to ask her, hey, should we do a limited panel for this patient? Should we do a limited BRCA testing for this patient? And so it's great to have you here, Meenal. So what will you say about breast cancer that actually is familiar? We know 85% of breast cancers are sporadic. Most women, so if any of you think that, okay, how come I'm the first one in my family to get breast cancer? Well, 85% of cancers are not genetic, they are not hereditary, they're not caused by known gene mutations that run in your family or genes that you will pass on to your children. If you have a family history of breast cancer, you are at slightly increased risk of breast cancer yourself, but not all those cancers are going to be hereditary as we know them. So Dr. Meenal, what would you say, like, who are the patients that should be concerned about whether they belong to that 5-10% group where the cancer might actually be genetic and caused by specific gene mutations?
Yeah, thank you for that question, Dr. Pranjali. Excellent questions. And in fact, if you would have asked me these questions 5 years back, I would have said, yes, we would recommend genetic testing in a small percentage of women that you rightly said. Only 10 to 15% of women actually have the mutation, genetic mutation, what we call it, commonly called as BRCA1 or BRCA2, though there are other genes as well. So as you rightly have pointed out here, if you are young breast cancer patient, age less than 50 years, if you have a history of close family members, like in your first degree relative, like siblings and parents, have a history of breast or ovarian cancer, or then the nieces, the grandparents, the uncles, aunts, then probably you may have a higher risk of genetic predisposition. Yes, that's correct. But if you ask me today, because we know there is more awareness, there is more availability of genetic testing, there is more understanding how to treat them, I think every woman who is having a breast cancer or as a history of a close family members affected with breast cancer, especially at early age, I would recommend at least they should be given an option of genetic testing. Let's discuss about their risk based on their personal family history, their profile, tumor profile, and then they should be deciding that whether they should undergo genetic testing or not. So I think every woman has a right to understand their risk of breast cancer and decide for themselves, even if it is 10%.
Very true. So one thing I will say is, we have conventionally referred as oncologists to these NCCN criteria of who should
Yeah,
undergo genetic testing. And one thing I will say at baseline is genetic testing is not recommended for the regular woman who is walking on the street, doesn't have breast cancer, doesn't have a family history. We don't recommend population wide just going in for a blood
yes,
test like you do for a
yes,
hemogram. Once you've had breast cancer, there are multiple factors, some of which genetic, some of which environmental, and
yes,
conventionally, we've referred to these criteria that I've listed here. So if a woman has
correct.
breast cancer on both sides, if she has triple negative breast cancer, which is a specific subgroup of breast cancer under the age of 60, if a male has breast cancer, if there are multiple family members within one side of your family that have had breast and ovarian or sometimes other cancers like pancreatic, colon, thyroids,
And
they
prostate,
present
and not to forget prostate, which is a common
prostate.
cancer. Yeah,
Very then those patients we generally reflexly refer for genetic testing. Now, there were some
right.
studies in the recent years which looked at, well, if we use these criteria to figure out whether women should undergo genetic testing, and if we don't use these criteria and just test everybody who's had breast cancer, are we
Hmm.
picking up a large number of genetic, abnormalities in this group compared to the other group? And the answer was no,
Actually, no. Yes,
right?
that's
So
correct.
which
Yeah.
means we are not very perfect with what we know about who is at genetic risk and
Yes,
who is not. A lot of these criteria are being used by insurance companies in Western countries,
correct.
like, allow or deny genetic testing to women. So an educated woman who simply wants to know, okay, well, I want to know what my risk of having a genetic type of breast cancer is so that I can manage my own risk of future cancers.
Yeah,
And I can, have an educated discussion with my family, advise my children at an appropriate time. She should be given the opportunity to at least learn about genetic testing. So for those
exactly.
of you who
Yeah.
have visited our website, the www.punebreastcare.com, there's a whole page we have created for genetic testing and for women to learn more about this topic. And we can share that link in the chat box in a little bit.
Yeah, and that would be helpful. And I would request this group of women not to randomly search on Google about these breast cancer genetics. They will give you lots of information actually, which is not correct. I mean, not correct, it is inappropriately put, I would say. So please go for an authentic resource. So if Dr. Pranjali has put it, I would definitely go for it.
So now what do you do when a woman comes in for genetic counseling? So, as a surgeon, I usually have already talked to her about, okay, what are we
Correct.
going to do with the information that we get from a genetic test? There is no good or bad result, right? When it comes to a genetic test, your genes are already what they are. And how are you going to use the knowledge of that test
Correct. Yeah.
to actually better care for yourself, decrease your risk of recurrence or a new breast cancer, rather, not recurrence, but a new breast cancer or an ovarian cancer or whatever the syndrome that we may be looking at? How are you going to actually use that information? And the truth is, today we have so many measures available to us to decrease this risk. And that is why this is worth doing at all. It is not something
Exactly.
simply to punish you that now you have to live with this, idea that, oh my God, I'm going to get future cancers. No, the idea is to decrease your risk, because now we know how to decrease your risk. So what do
Exactly.
you do when you are doing a detailed genetic counseling for a woman? What do you do at your end?
Yeah, so to simply put it here, genetic counseling, a pre-test, it means we are doing this session before test, which is absolutely must, because this is not a simple blood test, which you will walk in a laboratory, give yourself blood and get a result as a positive, negative, or good or bad. Genetic testing needs a personalized risk assessment. So during a genetic testing pre-test counseling session, usually the protocol is to go through your family history, your reports, the age of onset, your biopsy finding, and look at in detail to assess what is your risk perceived for a genetic mutation. That is what is called as a bad genetic bad gene in your genome. And then we will discuss about what is the right genetic tests for you, because there are so many laboratories, so many genetic tests available. So you need to, or your doctor needs to choose among those from them. And during session, we always explain what are the possible outcome of genetic test, because as Dr. Pranjali rightly said, there is nothing like good or bad. A genetic report, as I see it, is a definite and or not definite. A definite report can be a mutation positive or mutation negative, which will give your oncologist or oncosurgeon or your doctor give a chance to take an informed action about your surgery, about your chemo prevention, and actually managing your lifestyle, because there are chances of recurrences in other organs as well, or cancers in other organs as well. But sometimes, about 10 to 30% of the times, you may get a report which says the findings are not certain. In that case, most of the times the laboratories talk to your doctors. I frequently have a conversation with Dr. Pranjali about a patient, and together we decide, okay, whether this genetic report needs to be considered in the management or not. So this is very, very important. You have to undergo a pre-test genetic counseling session before undergoing this BRCA testing.
Yes, very important point. And we absolutely would not recommend anybody to do a genetic test and ship it off to a genetics lab without undergoing
Yeah.
a proper genetic counseling, because the implications of this are important, not just for you, but for your family members as well. So what actually happens in your lab? When I send you a sample, usually I send you like a 3 ml sample, as you've told me, in an EDTA bulb, and it's straightforward for me to collect the blood and send it over to you. But what happens at your end? And why do the report, like patients are like, why does it take 6-8 weeks for the report to come back? Like, because they're used to getting their hemogram reports the same day. So how is a genetic test that also seems to be a blood test? Why is that different?
Yeah, exactly. Very nicely put. So from a patient's perspective, what I do is I give my blood, I give money, and I get a report instead of 2 days or a 1 week. I get a report in 2 months' time, not 2 months, maybe 1 month, 3 to 4 weeks' time. But actually, what is happening on the background? From the blood, we are collecting the DNA, which is an encyclopedia of all your genetic material. Imagine is like a full dictionary. And in whole dictionary, we are finding a spelling mistake. We are reading it page by page, sentence by sentence, and word by word. And despite the advancement of technologies, it takes time. And even if we find the spelling mistake, which we called as a mutation, we have to see it is only in the British dictionary or exists in Indian dictionary as well. So we have to sometimes struggle a lot to understand what this spelling mistake means to you. And that is why these reporting and interpretation takes time, 3 to 4 weeks. And Dr. Pranjali knows it. And many times I call her up. Hey, I see something which is not related to breast cancer. Do you see some history of colon cancer, like in intestine cancer or a prostate cancer? Do I need to extend my analysis to other genes as well? So many times this to and fro conversation between your lab and your physician is required. And that's what takes time. This is usually typical 3 to 4 weeks. But however, in emergency situation, we can pull it off within 10 days or so, but we will keep it only for emergency situations.
Great point. So yes, it's a lot of work that goes behind the scenes in a genetics lab, and there is a lot of data that needs to then be analyzed, cross-referenced, and interpreted, which is where a lot of the time gets taken as well. So, and then when it comes to options, so if a woman, let's say you do pick up a gene and you do have a harmful mutation in, let's say, BRCA1 or BRCA2, you've already had one breast cancer, let's say. What needs to happen then is we need to have a detailed discussion about what are the implications of finding this gene, because women often think, well, I already got breast cancer, so now what's the use of telling me that I have a gene that could cause breast cancer? Well, it affects your future risk of developing a second breast cancer, either in the same breast or the opposite breast, your future risk of developing ovarian and fallopian tube cancer as well. And there are certain options which we can then offer you acknowledging this risk. So a contralateral, like opposite side breast cancer risk, can be as high as 40 to 60% for a woman who's had breast cancer on one side if she has the BRCA gene. Her risk of developing ovarian cancer again can be as high as 60% at some point. And it depends on which gene, what is the general pattern within the family, and those numbers are not exact for every patient. But we have to acknowledge that there is a much, much increased risk of a second breast cancer and ovarian cancer in these women who have an abnormal BRCA gene. So what are the options there? One is you could do high risk surveillance, where instead of simply seeing you with once a year mammogram for the opposite side, I may actually see you 6 monthly. And I may do not just mammography, but I may alternate that with a breast MRI, which is a way more detailed and a more time consuming and a more expensive test. And alternate that every 6 months with an MRI. So if you get an MRI today, you get a mammogram in 6 months, then again 6 months later, you get an MRI, then again 6 months later, you get a mammogram. And you pretty much have to continue this as is recommended for the rest of your life. And this gets to be a very taxing routine. But for a lot of women, they're not ready yet to undergo any preventive surgery. And this is an option. Now, this option doesn't prevent breast cancer. What this option does is, if you were to develop a breast cancer, which is a very high risk in your case, we will pick it up early in a way that it does not affect your survival. That is the goal, just like early detection in other contexts. In screening for ovarian cancer, we may ask you to do a pelvic ultrasound. We may ask you to do a CA 125 level, which is a marker for ovarian cancer. But again, it's not raised in every type of ovarian cancer. And unlike breast lumps, which can be felt from the outside, ovarian cancers are not easy to pick up in early stages, which is why this screening is important. But again, this screening is not going to be foolproof. And in some patients, when we pick up the cancer, it may already be a late stage cancer when it comes to ovarian cancer. So because of this high risk and because surveillance is not going to prevent cancers, another option is a surgical risk reduction. And most of the time, those of you who have BRCA mutations and who have had this discussion with me, if you have completed childbearing, I will recommend that you go ahead and at least start with the prophylactic or the preventive removal of the ovaries. Now, this is not done in young children or in teenagers or in your 20s. We do have, ovarian cancer is not going to affect you at the age of 15 or 20 or anything like that. So there is always, usually there is time to complete your family and then undergo these preventive surgeries. As far as options for the breast are concerned, we are doing today what we call as a immediate reconstruction in the context of what we call as a skin sparing mastectomy. I know these terms sound very fancy, but what it essentially could imply is almost like a breast replacement surgery. What that means is, for women who need preventive breast surgery and they don't actually have breast cancer, we leave the skin envelope on top as it is. We remove all the tissue or the gland which is at risk of developing breast cancer from a hidden scar, and we replace that with a implant or a flap. So these are the type of reconstructive surgeries we do, and we're going to be talking to Dr. Swapna here, so I'm not going to go into detail. But women, often I will show pictures of what a preventive breast surgery looks like way before a woman is going to undergo genetic testing. Because a lot of women fear that, oh, if I have the BRCA gene, I have to walk around after a mastectomy flat-chested, and that is absolutely no longer true. So preventive surgery works beautifully. It decreases your risk by over 90% for both breast as well as ovarian cancer. And the last, there is an option of chemo prevention. It's not chemotherapy, but it's hormone therapy. Drugs like tamoxifen can be given to patients who have BRCA mutations, but they do not completely prevent all types of cancers, because then that would have been super easy. We would have just put you on a pill and you wouldn't get breast cancer. but they do work in decreasing risk perhaps of certain types of breast cancer. And the third last point is that, if you are picked up with a breast cancer gene like BRCA1 and 2, you need to know how to actually talk to your family members about it. And this is where Dr. Meenal comes in again, and you would guide patients about how are they going to actually have this discussion. Look, hey, look, I underwent genetic testing for this particular reason. I was found to have a harmful gene. You are my sister. Your probability of actually having this gene is about a 50-50%. If you would like to learn more, here's Dr. Pranjali's number, here's Dr. Meenal's number, this is our website. You can go learn more about genetic testing. And if you choose to go ahead and do it, I'll help you find the right team to undergo this test with. Your test is not going to be as time consuming and expensive as mine, because you already know the mutation that we are testing for. And so this is the sort of language that we equip you with, so that you can actually have a conversation with your parents, your children, your loved ones, and then discuss who amongst them actually needs to undergo genetic testing. So Dr. Meenal, do you have anything to add to these options here?
Yeah, just one comment. As you rightly said, breast and ovarian cancer are not going to happen to their childhood age or teenagers.
Yeah.
So I understand parents' anxiety to test their own kids for this BRCA mutation if they are tested positive. But trust me, this is not going to help them if you do it before they become 18 years of age. So usually we all recommend, if anybody in amongst your children need to be tested, the testing needs to be done 18 years or later, so that we can give them informed choices, what Dr. Pranjali talks about. Do not get anxiety that your kids might get it. The chance is only 50-50. They might not get it. So just test it at 18 years of age, which is appropriate.
Yes, and that's that individual's choice, right? At the point at which they are able to understand implications of genetic testing, they can very well exercise the choice to not want to know, and we can equip them with all the information and advantages. But ultimately, whether to undergo genetic testing or not is that individual's choice. So now coming to, we briefly touched upon breast reconstruction in the context of preventive mastectomies. We certainly do it in patients who do have breast cancer. And there are some of you here who may have had a mastectomy, not had a reconstruction, maybe because it was not offered to you, maybe it was not feasible at the time, maybe at that time you were so focused on cancer that you didn't want to think about the cosmetic aspect. And we do offer delayed reconstruction for such women as well, if that is what they choose. So I'm going to ask Dr. Swapna Athavale here, who's my plastic surgery colleague and friend. What would you say as a plastic and reconstructive surgeon about types of reconstruction options that are available to women today?
Yeah, I can see many of my patients who had already underwent a reconstruction surgery, either primary or secondary reconstruction. So we would like to discuss what are the different types of reconstruction options if we want to remove a whole breast, part of breast, unilateral breast or bilateral breast. So there are, according to timing, there are two types. One is primary reconstruction, that is immediate reconstruction, and the other is secondary reconstruction. And I would like to add one more type in this, that is delayed correction after primary reconstruction, delayed reconstruction, or the patients who have underwent breast conservative surgery, whether there is change in volume, size, shape, or nipple orientation. So the third category I would like to add is delayed correction of whatever surgery they have undergone previously. So primary reconstruction is the reconstruction when we reconstruct breast at the time of primary surgery. Whenever onco surgeon or breast surgeon is removing a whole breast or part of breast, we reconstruct the breast either by using implant or the own muscle or abdominal flap. That is called as primary reconstruction. So primary reconstruction is the reconstruction of breast at the time of primary breast removal surgery. And there are many advantages related to that. Who are the candidates? There are multiple factors which will decide whether patient can undergo primary reconstruction or is a candidate for secondary reconstruction, whether there are multiple criteria, the stage of tumor, size of breast, then size of the opposite breast, and then what is the histopathological grading of that tumor, what is the age of that patient at the time of surgery, post-operative radiation is required or not, then availability of various donor sites, whether patient, what is the profession of patient, and then anesthesia risk, whether patient is having uncontrolled diabetes, hypertension, or some comorbidities that can restrict, the time period which is required for this reconstructive surgery is a little bit more than the normal without reconstruction. So anesthesia risk should be considered, and the post-operative course of that patient should be taken into consideration. So we, myself and Dr. Pranjali, we have individualized or customized, options for each and every patient. We need to and we need to have a discussion without like with all these options with patients and relatives, and then we give them options, what are the better options for primary reconstruction out of all these criteria. And then we always have a discussion with our patients preoperatively regarding various options available and what are the indications, contraindications of that particular options, and then we decide what particular reconstruction is ideal for that patient. So this is about primary reconstruction, which is always preferred over delayed reconstruction. Previously, the options were not available, or some of the Indian patients are not very much oriented to the options available at the time of surgery. So many of our patients who have missed primary reconstruction, they have the options of delayed reconstruction, which we do almost after a year of finishing their radiation and chemotherapy, and they need to undergo, Dr. Pranjali first examines them and make sure that there is no risk of cancer recurrence and they are free of disease for more than a year. Then we can opt for delayed reconstruction. So what are the options again? We again examine these patients for delayed reconstruction, and based on all these criteria which we have discussed, there are options of either using implant, expander implant, or their own tissues in the form of abdominal flap like tram flap or DIF-free flap, or sometimes we use a combination of muscle from back, that is LD, latissimus dorsi muscle, which is a vestigial muscle in human being. So that muscle in combination with breast implants. So we do secondary reconstruction. And there is one more type that we want to discuss is, what if the patients are not very satisfied with the results of primary reconstruction, or patients after breast conservative surgery, they want to match the size of breast volume, or they are very much concerned about scar or any sort of there is puckering, or they want to correct the symmetry of breast, then that is called as delayed correction. So there are new advanced techniques which are available for delayed correction, like fat grafting. We can harvest a fat from abdomen subcutaneously, do liposuction in that area, centrifuge that fat, and we can put that fat in the breast who wants to, get matched with another breast to match the volume of two breasts. So there are multiple options available nowadays. So I would like to hear from all my patients what is their feeling. Basically, the most important factor is that social behavior after this breast surgery, and their confidence to wear their normal dresses, dressing style doesn't change after surgery. So the patients who have missed primary reconstruction, they can go ahead and discuss with Dr. Pranjali or myself regarding what are the various options about delayed reconstruction. And it is very simple surgery, almost admission for 2 to 3 days is required. And nowadays, many of our primary reconstruction patients are also opting for insurance clearance, and we are also, counseling them for getting into uh, bilateral reconstruction if they are BRCA positive, and there are various options available.
Hey, Dr. Pranjali, I think you're speaking on mute.
Hey, thanks so much.
Yeah.
So thanks, Dr. Swapna. Those were great points. And when it comes to reconstruction, it's not one size fits all. It's usually one size fits one. So it's a very individualized and personalized decision that goes into the decision about reconstruction. So just like if you were going and buying yourself a pair of sandals, you're going to pick something that represents your style, your size, that is going to support your body well, that is going to fit your routine of work, and your feet aren't going to hurt at the end of the day. Similarly, when you're picking a type of reconstruction, the same thought goes into that. What is your lifestyle? What is your sense of, body self-image? What are your um, what is your routine like? Are you a tennis player? Are you a football player? Are you somebody who does abdominal crunches? And your general health as well. And all these decisions are going to go into what type of reconstruction we would offer you. I would say that almost every patient, there is some solution that we can make work, and if not today, at least at some point in the near future. So don't hesitate to discuss reconstruction. It's an important topic. It is important to women to have a complete sense of self and body image after having undergone a breast cancer surgery. And reconstruction has almost become part and parcel of our routine cancer surgeries today. Now, there is a group of women who may not want to undergo reconstruction. And my next question is for Dr. Rohini again. What are the options for women who don't want to undergo a reconstruction or haven't had a chance to undergo reconstruction, to wear a prosthesis externally, and what are some types? And you have been extensively involved with this movement that you educated me on called knitted knockers, and Dr. Kalpana Gupte was also here. Mrs. Kalpana Gupte was also here a little while ago, and she is helping donate these soft prostheses to our patients at Pune Breast Care, at Jupiter Hospital. So Dr. Rohini Patel, what can you tell us about this movement and options for breast prosthesis for women?
Yes, after mastectomy, there are few people who really wish to go flat. If suppose they go for a bilateral mastectomy, they are comfortable going flat, but then few of them, they feel very uncomfortable. They seclude themselves. So there are two or three options. One is a traditional breast prosthesis, but then because of this cost, few people find it very expensive, few people find it very heavy, few people find it sweaty. So they want some other options, and few of them, they go for post mastectomy bras. Generally, that bras, one cup where one is operated, the side one is operated, is stuffed with foam or something. But then that also doesn't make the person who's wearing it very much comfortable. And we at Knitted Knockers India, we are a group of volunteers who knit and crochet and make handcrafted breast prosthesis, and which is absolutely very comfortable, washable, can be used much earlier in post-op period than the traditional breast prosthesis. And it is made up of mercerized 100% cotton and filled up with hypoallergic polyfiber. And important is this prosthesis can be customized according to the individual need. We always say that the survivor herself is a unique, and so her prosthesis is unique. Okay, so this is how one can be going in for the handcrafted breast prosthesis called knitted knockers, and it can be customized to match the other contralateral breast. They can be made sagging by adjusting the polyfiber. It is washable. You can remove the polyfiber and you can fill it. It comes in 4 sizes of cups, that is A, B, C, D. And we teach the survivor how to customize according to her need. So we do have an option of traditional breast prosthesis and the knitted knockers, and also the prosthetic bras which are available.
And I'll be sharing the contact information if any of you want to get a hold of one of these knitted knockers. And I think you should if you are, if you haven't.
This is what it is.
A mastectomy and don't have a reconstruction, please reach out to us and we'll make one of these.
Yeah, they are beautiful. They're soft.
Lovely. So the next question is going to be for Dr. Priyadarshini Kulkarni. She's our palliative care specialist, and she works with cancer patients at a time when they don't have a lot of resources. patients who are dealing with end of life care, patients who are dealing with support issues, even when they're not going, even in early stage of cancer, patients who are dealing with pain, patients who are dealing with symptoms that can be addressed, which may not directly come under the purview of an oncologist. And one of the important areas where she offers support is having a conversation with caregivers. So, Dr. Priya, what would you tell us about the care that we need to take about for our caregivers? So sometimes it's a spouse who's the primary caregiver, sometimes it's a parent, sometimes it's a child. How should caregivers recognize that they also need support?
Right. Thanks, Pranjali, for this wonderful session. Of many things, I'll right now only focus on caregiver support, but palliative care does work for symptom management, including pain management. And the message I want to give all the patients here is at any point of time in your journey, you should not be tolerating your pain. Just connect with us and we will try our best scientifically reduce your pain. So coming to caregivers, many of us don't understand that when these are chronic cases where you are diagnosed with cancer, then you undergo treatment, then the chemotherapy continues, and it goes on and on and on. And at some point you also have like 3 monthly reviews, then 6 monthly reviews, and 1 yearly review, and this test and that test. Nobody really gives that much attention to family member who's all the time accompanying you. But the thing is, they are also individuals. They have also made sacrifices. Somebody has left their job, they have taken leaves as much as you are, and they are the source of strength to you. It's very difficult for the patients to understand that beyond their whatever they are going through, to understand for the other person who's all the time supporting them. But they need the support. In palliative care, we say that caregivers who are chronically being there with patients who need long term care, they are as good as second patients. They have compromised on multiple levels and they need support. They can't really come out and say that they are tired. They can't really say that my social life is changed because you have become a patient, because they are expected to behave all the time like a mature persons. I think whether you are a patient or not, we really need to understand that these are the silent people who are suffering with you, and they need some compassion. They need something that they get relaxation in, for even it is for a day. They need to have some regular breaks. And I think being in palliative care, we work with our counselors who understand their needs, and we understand what are the alternatives we can provide patients and families with, when to get other people to come in at regular intervals, or we can suggest them some regular counseling sessions with us as well. So understand this much, that with you they are also going through this journey where they also need support, and there is a support available.
That's awesome. I think it's a great point. And I think even as oncologists, we're not giving enough attention, right? We're talking to the patient who's in front of us. We're doing a physical exam. We're making sure they're okay. And then we look at the caregiver who's next to them and tell them, okay, they're okay. And we don't ask this person, are you okay? And is there something we can do for you? And direct them to help that they would need, and helping them recognize that. So lovely points. Now, another problem I think that often gets neglected in assessing oncological patients in follow-up is their mental well-being. And a lot of times stress, anxiety, sadness, some mood changes are expected in the cancer journey. Initially, there may be a sense of like, bargaining, anger, grief that we talk about, the usual phases. But even many years after cancer treatment, cancer treatment, some women are really struggling with major depression. And what I want to ask Dr. Priyadarshini Kulkarni is, when should a family member recognize uh, this stress and sadness as not just being a phase, but actually being depression, and bring it to the attention of the oncologist, the palliative care specialist, the counselor, the psychiatrist, whoever it may be? But how do we recognize it?
Right. It's a great question, Pranjali, and I think all of us, those who are involved in giving care, as well as family members, need to understand that this might happen. You know, as normal people, they get depressed sometimes, like in our routine life, somebody loses their job and so on and so forth. They are likely to be depressed for some time. Same way, when patients are diagnosed with cancer and they are rushed to all the treatments, and they certainly get on that cycle of getting treated, and always there is a hope, there is a anxiety, and they go through these emotional ups and downs. That's all right. But when you see you have been living with this person for some time before they are diagnosed with cancer and going through this treatment, when you see that, you know, about a week, generally I tell them that if the symptom of depression comes today and she is fine next day, you know, it's time being. But if you see the person, the patient who's undergoing the treatment is not ready to, or not, or cannot come out of their depressive state, their mood, they are not looking forward to doing anything. They don't want to, they're not excited to go for visiting the doctor. They don't want to see their results. They are not interested in surroundings, what's happening to kids, their school. No such questions. If this happens for about a week, I think it should raise the index of suspicion in your mind, and that's the time when you should mention it to your treating doctor. The other thing is, it is best, depending on your communication in the with the spouse, or if you are a parent, you should directly really ask, are you depressed? There are many tests which clinicians, counselors, they do to find out whether patients are clinically depressed. But there are also studies that when you directly ask patients, are you depressed, many a times, like 70% of the times, if they are really feeling like that, they would open up. So at least we can do that.
Yeah, and don't be afraid to ask, right? At the most, they may say, no, I think I'm okay. Or maybe, you know what, you said, now that you bring it up, I realize this could actually be depression and it's not just a phase. And there are these myths we have about depression that, some people think, well, a depressed person can simply snap out of it, get to be normal. You're just not trying hard enough. Or what is there to be depressed about? You're doing okay. Your cancer is gone. You have people who love you, and you're not being ungrateful for those things. You're not somebody who is has all the good things in life, and yet how can you be depressed? Well, this depression, just like any other illness, is an illness. And depressed people are not trying to get your self pity. In fact, they're in a state of chemical imbalance which we can actually alter. And people are very afraid of taking medicines for depression because they think these are addictive substances, they're going to change their personality. But if you have been prescribed something for depression, take it. If you've been prescribed therapy for depression, do it. Another very important points that Dr. Priya made, it's not always that somebody is crying and crying and that means they are depressed. Depression is not always somebody who is crying their heart out. And in fact, people who are expressing their emotions are in a better state than women who are actually keeping it all bottled inside. So anything else, Dr. Priya, you would add about myths about depression and what to do or what not to do if you are depressed?
Yeah, I think the most important thing for patients to understand, that if you're feeling not normal, you know, going through this treatment, as Pranjali said in the beginning, that you are not alone. There are people out there who can help you out. So once you understand that there are people who can, or who may be of help, don't keep it to yourself. You have to communicate what you feel, either to your loved ones or to your doctor. There are ways to treat it. And as we are taking medicines for blood pressure, diabetes, it, people take it for time bound things. Antidepressants are medicines to correct your depression. It might help you to go ahead and complete your treatment in a better way, and there are positive outcomes of taking these medicines. You're mute, Pranjali.
Another practice that is being talked about a lot, and a lot of research has gone even into breast cancer survivors, is the practice of mindfulness. And when women often think about meditation in the context of cancer, they're like, well, I'm going through a whole lot of things and you expect me to sit down and quieten my mind and meditate, and I'm not going to be able to do that. And people get very stressed out about the idea of meditation. And a newer concept is something called as mindfulness. So, Dr. Priya, would you like to tell us something about what is mindfulness and how it can help somebody to just maintain their mental well-being, if not acutely correct it?
Okay, I'll take that, but at the same time, I'll tell that I'm not the expert who deals with these topics. However, whatever I have understood uh, from all this dealing with patients who have diseases or problems like cancer, that it is a body and mind game. So once you are into the treatment, if you are very positive about that, yes, I want to complete the treatment, I want to get out of it as soon as possible, that positivity helps you go through your treatment definitely better than somebody who says, oh, now it's cancer, and whether it is stage 2 or 3 or 4, whatever it is, I know the end result. I want you to understand that all of us know the end result, and we are not talking about that end result right now. We are talking about how to make it better with all your positivity.
Very true.
What is important once you are diagnosed with cancer is to accept the fact that you have cancer, to accept the fact that there are treatments available, and accept the fact that people do get better even if they have cancer. With that positivity, I think more than this, if any other panelists want to add.
One thing I have learned about mindfulness is it's about being in the moment. So it's not always like, when you're talking about mental relaxation techniques and meditation, it's not just about going and sitting in a quiet mountain or in the corner of your room and closing your eyes and trying to shut off your brain, because people think, oh well, when somebody tries to tell me to relax, I get even more stressed out because I have 1,000 things at the back of my mind. I have 1,000 work things, cancer related follow-ups, family related cares. What mindfulness talks about is giving yourself breaks of a few seconds in your routine, simply focusing on the task at hand. What that means is, supposing you are washing dishes, focus on the task that you are doing. Focus on what the temperature of the water feels like. Focus on what the soap makes your skin feel like. Or if you were eating something, if you're eating a raisin, this is an often cited example in mindfulness books, that if you're eating a raisin first, try to see what the temperature of the fruit you're eating is. What does the texture feel like on your tongue? What does that fruit smell like? Being there in the moment, doing the task that you're doing and experiencing that at that particular moment in time. Which means when you're washing dishes, you're not actually thinking about your meeting that's going to happen tomorrow. Inadvertently, that is what we do. If we're brushing our teeth, we're figuring out, what are we going to wear next? But if you give yourself a break and spare 10 seconds, actually make focusing on the task of brushing your teeth and focusing on the taste of your toothpaste and how much cleaner your teeth feel at the end of the task, that actually gives you a lot of mental relaxation, and that can be achieved no matter where you are, whatever you are doing. So it's not always about isolating yourself to give yourself a mental break. And I think for those who are interested, there are some great resources on mindfulness. Please do look them up. Now, Dr. Priya, your specialty is palliative care. We touched upon that a little bit. But when is the right time to involve a palliative care doctor? And what is it that a palliative care doctor actually does in this field? I know you as a person do hundreds of different things, but what is it that palliative medicine is about? And what can you tell our patients about involving a specialist in this field in their cancer care?
Sure. Thank you for this question again. That many of the patients don't know this word, what palliative care is, and those who know, they really think that it is only in the late stages of the disease. I think once you are diagnosed with cancer, palliative care is your friend in many ways. Palliative care specialist or the team of people can help you not just relieve your symptoms like pain or ascites or breathlessness. Sure, they would contribute in addition to your primary doctors, but they are also there to help you accept your disease, understand your social, psychological, and even questions what you have, like, why did I get this disease? They may not find answers, but they can certainly help you find your answers. So, palliative care doesn't really is end of life care. It starts from the beginning of diseases like cancer. It is not only limited to cancer, but the conditions where, there are irreversible conditions like Parkinson's, dementia, even pediatric population. In children, there are certain conditions where complete cure is not possible. We can still make comfort as our goal of care when cure is not the goal. Yeah, and one more important thing, that when somebody is seriously ill or terminally ill with cancer and they pass away, palliative care also helps family members to come back to near normal or new normal without this person in their life, in terms of grief and bereavement management, which is an important area of palliative care as well.
The amount of work that has gone into this field and the amount of work you do for these cancer patients is absolutely commendable. And also, I would like to add, Dr. Priya, is not it's not just palliative care is not just for cancer patients, although this is a topic that we are dealing with today. It does apply to patients in similar stages related to other diseases as well. So some specific symptoms we are going to talk about, and I'm just going to go through these in brief, are, if you have chemo-induced neuropathy where you're struggling with, say, pins and needles kinds of sensations, you're having difficulty doing tasks like buttoning your shirt, tying your shoelaces, if you're having pain from neuropathy. And neuropathy, like I said, is just nerves getting damaged to one extent or the other because of these chemo drugs like taxanes and platinums. There are certain options available to you. One is, yes, there is a diet plan, there is antioxidants you can take, but they are not going to be foolproof and fix the problem. So again, this comes into the spectrum of what we call as a new normal and working around this limitation to manage your lifestyle. In these cases, you can certainly involve an occupational therapist like Dr. Sharada to help you do the tasks that you actually need to do in spite of this limitation. If you have pain from your neuropathy, you can see me, see Dr. Priya, to manage this pain, because like we said, we don't want anybody living with pain. There is something we can do to, if not take away your pain, at least lower it. And so for neuropathy, yes, there are some medical options, and especially if there is pain, and there are rehabilitation options as well. Now, skincare, if you've recently undergone radiation, follow the advice of your radiation oncologist about how to care for your radiated skin in the early phases. Keep it clean with soap, mild soaps and warm water. Don't apply things that have not been approved for use for you yet. So don't apply toxic, don't apply deodorants and harsh sprays and lotions and talcum powders. Wear loose fitting clothes, avoid sun exposure. Now, sun exposure is easy to avoid when you're looking at an organ like the breast or chest wall. However, sun exposures up here above the clavicle, if that's what you got radiated to in the area close to your neck, That is also important, keeping that area covered and away from the sun so that your radiation damage doesn't get exaggerated. If you are having dermatitis where your skin is irritated, or if you're having blistering, then use the therapies that your radiation oncologist may prescribe. They may give you some oral medications like steroids. They may give you some topical creams. Don't apply, excess heat or cold to that area. Don't, if you're going in for a shower, always check the temperature of the water on your non-operated, non-surgical, non-radiated side before you take, bath water onto the side that has uh, been treated. Don't put tapes, bandages, anything sticky, and when you're following care for your radiated skin. Another common problem that we neglect is sexual dysfunction and pain during intercourse, recurring UTIs, all caused by vaginal dryness from some of the therapies we're giving you. So, and some of these treatments may be, ovarian suppression, tamoxifen, aromatase inhibitors. All these contribute to lowering of estrogen in the body. So if Dr. Rohini Patel is still here, Dr. Rohini, would you like to answer this question about, are there options for women, because they're worried about hormonal content in vaginal creams like estrase, increasing risk of breast cancer. So what can they use for some of these symptoms that women may be going through?
Yeah, Pranjali, you rightly said that anti-estrogens, what we give for the breast cancer patients, they really make the vagina very dry and reduces the suppleness. So that is where the survivor has got a lot of difficulty and has a dyspareunia and painful intercourse. And there are two options for them. One is vaginal moisturizer. This vaginal moisturizer is a long-term thing, which is used whether the patient is going in for the physical intimacy, or that is intercourse, or not. And this keeps the vagina, helps to keep the vagina very supple and moisturized. And another option is the lubricant, which is used at during the act. But then if suppose these two are combined, they apply the moisturizer throughout, and as well as during the intercourse, they use the lubricant, then they are much, much more comfortable. And one has to be very careful about, which is a lot of talked about now, is paraben. And you should see whether the moisturizer or the lubricant is containing paraben, which is said to be having a low estrogenic activity. So that is what the options are for the breast cancer survivors to deal with vaginal dryness.
And so if you go with this symptom to your regular gynecologist who may not be familiar with your breast cancer history, you want to talk to one of us and show us what you've been prescribed, if you want to ensure that it doesn't have any estrogenic and phytoestrogenic components like Dr. Rohini Patel just said. So now we are at the end of our session, and I'm just going to list these resources here and contact information. So if you guys, I'll try to make a recording of this session available to all of you, but feel free to take pictures of these last couple of slides, because they're a great resource for whoever is looking for specific things and don't know where to find them. So for prosthesis, we have, in Pune, we have a couple of people who are actually supplying the silicone prosthesis as well. And for those of you who are immediately after surgery or don't like wearing the silicone prosthesis, we do have the graciousness of the Knitted Knockers group. Dr. Rohini Patel from Nagpur has started this movement. Mrs. Kalpana Gupte in Pune is running a support group for breast cancer survivors and is making these available to us at our Pune Breast Care Center as well, or you can reach out to them directly as well if you're not from Pune and need these shipped somewhere for you. Feel free to note down these numbers. For patients who are dealing with chemo-related hair loss, if that is affecting your social life, there are people who are making customized wigs and hair care solutions for our patients who have chemo-induced hair loss. So feel free to reach out to them. And again, we don't have any commercial associations with any of these people, but these are all great people who have been consistently working with us over the years and helping our patients out as and when they can. For genetic testing, you can contact me at my clinic. You can talk to Dr. Mina Lagarwal as well if you have any questions about BRCA testing. We do offer genetic testing through our center as well. For breast reconstruction, you can call me, you can call Dr. Swapna Athavale, who just gave us a detailed discussion on breast cancer, breast reconstruction. And Dr. Swapna and I are also doing a combined clinic for this specific area, which is reconstruction for breast cancer patients, cosmetic deformity corrections for cancer patients, as well as patients who have non-cancer related cosmetic breast concerns. We run a joint OPD where we assess the pathology of the breast, the cosmesis of the breast, the cancer-free state of the patient, all in the same clinic. And this clinic we're running at Jupiter Hospital on Wednesdays at 4 o'clock. If you are out of Pune and need a consultation, feel free to reach us on our phone numbers, and we can set up a teleconsultation for you as well. If you are looking for family and counseling and support, Dr. Priya Kulkarni has already told us that she's happy to help caregivers and guide them about how they should care for themselves. Mrs. Kalpana Gupte, I don't know if you're still here, Mrs. Gupte, but she runs a peer support group with a bunch of other lovely women who are also breast cancer survivors and are happy to chat with other women who are going through this simply because they need somebody. Women often need somebody to talk to. They have plenty of doctors, but it really, really helps to have the perspective of another breast cancer survivor. And a lot of you in this group have been very, very awesome. I know a lot of you all have over the years gotten to know each other simply because you all met each other in the same clinic, exchanged numbers, or we put you in touch simply so that you could share experiences with another woman going through a similar situation that you are. So there's this peer support group called Umarani, and the contact number for Mrs. Gupta is out there. Please get in touch with her if you would like to get into the support group. And for lymphedema management and any kind of physiotherapy, occupational therapy concerns, Dr. Sharada Umarani's number is out there. Her email is there. Shilpa, Shirole, you've been awesome guiding us about nutrition. And it's not easy to combine a whole vast topic such as nutrition in a couple of questions. And nutrition is really a personalized plan. So I would encourage any of you who are trying to eat right, who are trying to lose weight, please get in touch with these lovely ladies and let them guide you, because I want things to work out in the right direction as far as each and every one of you is concerned. If a lot of you have been supporting our NGO called iShare Foundation, we have recently launched a fund for needy breast cancer patients. And a lot of you have already donated to this fund. But if any of you would like to donate or would like to share this information with somebody who does want to donate to breast cancer, please feel free to reach out to us on our website, or you can get in touch with me. I'm one of the founders of this organization, and we will make sure that the funds go to the right place and are used for the right reasons. And we are ATG registered and tax exempt as far as donations go. So please help out. So if you've had a good experience, please try to help somebody who is financially needy and is trying to get breast cancer support financially. We have recently started our lovely independent breast center on BMCC Road. I'm just sharing my clinic photos because I'm just so excited to have this own place of mine now. Any of you who would like to get in touch, please feel free to do so. We are all women staff run clinic. We follow strict sanitation protocols, and we address absolutely any breast problem that you may be going through, including genetic testing, counseling for surgery, biopsy, breast ultrasound, cosmetic breast concerns. Just reach out. These are just some pictures because I'm excited about them. And the last slide is our contact information. If you need to reach out to us, please don't hesitate to do so.